Welcome to SMA's Southern Medicine podcast. Practicing medicine in the southeastern United States presents unique challenges for healthcare professionals. The South's heavily rural population and limited resources require medical professionals to be more resourceful in their approach to providing quality care. SMA's Southern Medicine podcast addresses these issues by drawing on the experience of healthcare leaders who provide a multi-specialty, interdisciplinary team approach to medicine for the purpose of providing better care for the Southern patient population. Hypertension is a leading cause of kidney disease, and in part 4 of this multi-part podcast series, Dr. Benjamin Broome, a nephrologist with Nephrology Associates in Birmingham, Alabama, and Dr. Donald DiPette, who serves on faculty in the Department of Internal Medicine at the University of South Carolina in Columbia, discuss why hypertension, from a nephrology perspective, is such an important cardiovascular risk factor. They also will touch upon the recent hypertension guidelines, as well as offer healthcare providers an overview of conditions that can warrant a nephrology referral. Thank you both for being here today. From a nephrology perspective, why is hypertension such an important cardiovascular risk factor and therefore so important to treat and control?
Yeah, glad to be back. Hello, everyone, Dr. DiPette, especially. So we've kind of hit on this to some degree in some of the previous podcasts. You know, along with diabetes, hypertension is by far and away the primary cause of kidney disease in this particular country. As I've stated, you know, in the past, the way I explain it is that high blood pressure over time is hard on blood vessels, and kidneys are little more than bags of blood vessels when we get down to it. Okay, so high blood pressure plus time, almost without failure, causes tissue damage, kidney injury, and leads to chronic kidney disease. Now, hypertension in general is just a very large topic. And hypertension not only affects the kidneys, but as you mentioned, is a huge driver of cardiovascular disease. High blood pressure leads to things like coronary artery disease, peripheral vascular disease, strokes, and other cardiovascular events, rather. And all of these things can lead to kidney disease, right? So you've got a patient who develops congestive heart failure over time because of high blood pressure. Well, that congestive heart failure and changes in their cardiorenal physiology can lead to decreased kidney perfusion and kidney disease and coronary artery disease and MI and the interventions that are required to take care of that, specifically with contrast, can lead to kidney damage and kidney disease. So, you know, it is all intertwined and it's hard to separate, but high blood pressure itself can lead to kidney disease. High blood pressure itself can lead to a lot of other comorbidities that also contribute to long-term kidney disease. So it is a very important topic to discuss and try to get a better sense of and better understanding in order for better control.
Dr. DiPette, do you have any thoughts or comments?
I think Ben summed it up very, very nicely. If you looked at all the cardiovascular risk factors, and I think what's important for our audience is, even though we're discussing hypertension today specifically, we're not talking about hypertension in a vacuum. We are talking about all the other cardiovascular risk factors: hyperlipidemia, diabetes, atherosclerosis, smoking, et cetera. On the other hand, though, to be fair, I'm a bit prejudiced. If you had to pick the number one leading cardiovascular risk factor, not only in the United States, but globally, it's hypertension. So this becomes important when you have limited resources or when the systems are under stress, such as COVID, et cetera, and you have to pick and choose. Unfortunately, we do not have to, but there are other countries in the world that do have to pick and choose what they're going to treat or what they're going to plan for later. Hypertension would be first on that list, especially in the realm of cardiovascular disease, which, as Ben has already eloquently discussed over this podcast series, the kidney.
Recently, there have been several hypertension guidelines released from not only the US, but Europe, and most recently from the World Health Organization. As expected, there are many similarities and a few differences among them. And in a broad sense, what do you believe the primary care provider should take away from these guidelines, such as when to start pharmacologic treatment? And once started, what is the blood pressure goal or target in the general adult with a confirmed diagnosis of hypertension?
Not only America, Europe, all over the world are, I don't think it's lost on anyone in the field that high blood pressure, as Dr. DiPette says, is a major comorbidity and driver of health disparities and poor health outcomes. I would say, from my understanding as not a hypertension expert in general, the guidelines are very similar in at least in their general scope and direction, that a lower blood pressure is better to prevent poor cardiovascular outcomes. According to the most recent US guidelines, they're actually trying to push their goal systolic blood pressure a little lower than I think what the Europeans are suggesting. But overall, there is seemingly agreement that lower is better.
Jennifer, let me go ahead and take a shot at this, since in all fairness, I think it's pretty well known that I've been involved in this process for quite a long time, and more recently in developing the hypertension guidelines that were recently released from the World Health Organization. Ben is absolutely correct. The trend over the decades, with a rare exception, has been that we are recognizing that lower and lower blood pressures achieve better and better cardiovascular outcomes and protects the kidney. And that is what you're seeing in these guidelines. I mean, even in our generation, in our lifetime, we have gone from no care. We didn't even understand or have pharmacologic agents to treat hypertension, to understanding that lowering blood pressure improves cardiovascular target organ damage. And that led into step care. Use one drug, particularly a thiazide diuretic, add another, a second, a third, a fourth as you need, to individualized care, where we started saying, well, you don't have to pick one drug for all. You can pick one for one ethnicity or race group or age group, et cetera, start another one, to more recently where we are today, which is in population-based care. So that's what we're seeing in general in terms of the therapeutics and the approach. But there's no question we're seeing that the recommendations are coming out from everywhere, from all sectors, from the United States. Europe has been suggested, now the World Health Organization, that we should start treating blood pressures at lower levels. That's the threshold blood pressure, that we should initiate not only lifestyle modification, which should be done in everybody, but also, more importantly, pharmacologic therapy. And commensurate with that, we're also then advocating for lower and lower blood pressure targets, which is the goal that you'll achieve. Now, there are small differences between the guidelines, but also remember they're coming from different countries. They're coming from different demographics, different income levels, et cetera. But in general, that's true. For instance, in the International Nephrology Association has just lowered their target diastolic blood pressure to less than 120 systolic. The World Health Organization, that's in the individual with kidney disease. The World Health Organization just recommended less than 130, as does others. So anyway, there are nuances, but there's no question that we should be treating blood pressure more aggressively, using more aggressive pharmacologic therapy, in addition to lifestyle modification, and driving that blood pressure down as quick as we can.
Yeah. And I do want to just kind of add, the difficulty for all of us is that, we have these guidelines, but they're guidelines. They're not straitjackets, right? So everything has to be taken on a patient by patient basis, and considering their comorbidities, their socioeconomic status, their ability to obtain, pay for drugs. I mean, there's goals, but then part of the jigsaw puzzle that is blood pressure management is, how do you achieve your desired goal with the patient that's sitting across from you in the exam room?
Ben, I can't agree with that anymore. I tell anybody who will listen, the guidelines are for the individuals or the population rule for instance, the majority of the individuals within that disease state or in that population or that geography, rather than the exception. On the other hand, I also don't want everybody to be an exception. So I think that we can approach a population group, adults, that are in the general population with no comorbidities as one group, another group as individuals that are at high cardiovascular risk, already have pre-existing cardiovascular disease or chronic kidney disease or diabetes as another group. And we can treat those populations relatively similarly because that's going to standardize the therapy, make it more acceptable and more available and more affordable. But then, as you state, in that exam room, there's always the final common pathway, which is a provider, there's a physician, practitioner, and that patient. And that's where the nuances can be discussed.
As a follow-up, and you both have touched on this just now, but kind of as a follow-up, are there different treatment thresholds and targets for individuals with the existing cardiovascular conditions, such as diabetes and chronic kidney disease specifically?
I would say that I wouldn't say there's different thresholds, right? I think it's becoming widely accepted that, as we said, less is more. I think the difference comes in the drug classes you may pick to treat or try to reach that threshold. It's very important to take into account comorbidities and other data and medication usage directed towards those comorbidities. For example, we know that patients who have diabetic kidney disease, especially proteinuric diabetic kidney disease, benefit from ACE or ARB therapy. So that would be a first class of antihypertensive I would grab or go to in that particular patient. We also know that beta blockers are great for patients who have cardiovascular disease, heart failure specifically. So that would be another first basket of hypertensive class that I would go to in addressing high blood pressure in a patient that has that comorbidity. And so you have to look at the big picture, and as far as directing your therapy, don't just pick drugs that you think is going to get the blood pressure down. Pick drugs that you think is going to get the blood pressure down, but also providing a secondary benefit for the comorbidities that are pre-existing.
Again, we've just touched on this a bit, but just if there's anything you would like to delve into a little bit more, once pharmacologic treatment is needed, are there specific classes of antihypertensive meds that should be used more generally, not so much for those specific conditions you just spoke of?
Well, Jennifer, that's a good question. And here's a great example of where the guidelines, no matter where they've been coming from, have coalesced. In the initial management of the hypertensive patient, most guidelines now are recommending any one of three classes: the thiazide or thiazide-like diuretics, the renin-angiotensin inhibitors, such as the ACEs and ARBs, the angiotensin-converting enzyme inhibitors, and the angiotensin receptor blockers. And the third class is the calcium channel blockers. And this gets even easier because most guidelines are recommending a long-acting agent from the 1,4-dihydropyridines, which in this case would be amlodipine. So that has simplified things a lot. The nuances get into what Ben talked about. If someone has comorbidities where another class of agent would be appropriate, the most common one that's brought up is beta blockers. Again, as Ben has already suggested, if the patient has coexisting heart failure or coronary artery disease, et cetera, then beta blockers, of course, are mainstay of treating that condition. But you wouldn't be using the beta blocker per se for the blood pressure. You would be using the beta blocker for the comorbidity and whatever the cardiovascular comorbidity is. And let's say it's heart failure, for example. This has made it a lot easier. I'll make a specific point. The reason that beta blockers are not being included as one of the main three classes for the hypertensive individual is predominantly because our concern that the evidence is not solid that they decrease stroke. And that has been one of our major concerns.
And just to kind of follow up on that a little bit, I agree that I think that those who study and report and write on this, diuretics are a huge class, and for any patient with I shouldn't say any, but the vast majority of patients who have hypertension. Since this is a nephrology series, I want to make clear that hydrochlorothiazide from a nephrologist is not thought to be effective below GFR 50. I see very few patients with a GFR above 50. So patients who are being treated with hydrochlorothiazide as part of their anti-hypertension regimen, I will often stop. Now I might switch it to a loop diuretic. I might consider spironolactone, again, considering some other comorbidities. I agree that diuretic therapy is beneficial for a large proportion of my patients. Hydrochlorothiazide in my kidney patient population, not thought to be the best bang for your buck. Chlorthalidone may be more effective to a slightly lower GFR, but maybe splitting hairs a little bit. So for a CKD patient population, thiazide, probably not your best diuretic to go with off the bat.
Ben, that's absolutely true. When we were talking about the guidelines in the major 3 classes, most of those guidelines are talking about the adult population, and the general population, et cetera. So absolutely true. That was interesting. Since you already brought it up, we might want to discuss it. The difference between hydrochlorothiazide and chlorthalidone, again, in an individual that does not have a low GFR or have CKD. We are now, to a greater and greater extent, advocating for chlorthalidone versus hydrochlorothiazide. Again, remember, this is for the non-CKD patient, only because of primarily because of its longer duration of action. They get greater natriuresis, and there's some studies that show that the blood pressure may be reduced to a greater extent than hydrochlorothiazide when equivalent doses are used.
On a dismal note, recent US data shows that the hypertension control rate has actually decreased from about 55% to 43% in the last report from 2017-2018. What could be some of the reasons for this alarming decrease? And are there newer strategies that could be implemented to turn this around?
Yeah, it's I think 43% might be generous. I don't know. There's a lot of things that go into this. And if you've ever taken care of a patient, you know these things, right? So some of the big things, patients don't want to take more pills, period. Doctors are scared to prescribe more pills, period. I'm not sure that we are doing the best job that we can getting accurate blood pressure readings or getting a great sense of what a patient's true hypertension status is in the majority of their life. In my particular practice, and I'm not saying that I do it, that my office does it the best at all, but we're rushing patients in. I've got 15-minute time slots. The nurse is running them back, putting cuff on, taking a pressure, writing it down. Patients insist when I ask them that they're checking their blood pressure at home and their home readings are better, or they tell me, oh, I just didn't take my medicines this morning. Oh, or I'm stressed. And then I'm hesitant to be aggressive maybe in medication changes because I believe them too much, or, I don't know. And so it is incredibly difficult, I think, to have confidence that we either are or not managing blood pressure appropriately most of the time. And then we all have our own, call them insecurities or hesitancies to let the patient think that we don't trust them or believe them, or to be aggressive ourselves and try to convince them they need more medicines. It's just, it's a lot of different factors that separate or make it difficult to really try to have a confidence that you're doing the best for your patient and that your patient is doing the best for themselves.
Jennifer, that's an ominous statistic that you just quoted, and that's coming from the NHANES data, which is our most recent data that tracks populations in various disease states, geographically, ethnically, and racially diverse in our country. For the very first time in our history, the hypertension control rates have actually declined. We can speculate forever as to what are some of the primary reasons. Ben already alluded to some of them. There are two big ones, however, are during this period of time, our comorbidities, which make hypertension more difficult to treat, are actually increasing. Diabetes, for instance, obesity, et cetera, are actually increasing. So it should come as no surprise that it's going to make the population, if you will, if we take a population-based approach, more difficult to control. At the same time, I honestly also believe some of it is on us, on the providers, on the physicians, and that's called clinical inertia or therapeutic inertia, where we, for whatever reason, it's human nature, we fail or we make excuses or we rationalize, and I'm being kind, not to up titrate a medication if they're already on one, to increase the dose, for instance, or to start a second agent or third agent or fourth agent to get that individual under control. And we take too long to bring them back. We don't bring them back in timely manners. And I'm basically talking about primary care here as opposed to subspecialty care, but we're all guilty. So I think that's where we're at. That has, interestingly enough, that report from NHANES prompted the Surgeon General of our country to issue a report, the first Surgeon General's report that I'm aware of, specifically around hypertension. There may have been some older ones, and it called it a call to action that we need a different strategy. We as a nation, as a community, as a practice, to more aggressively lower blood pressure. And some of these strategies are going to be very interesting. Again, most new guidelines are now recommending that we don't entertain starting one medicine anymore. That once the diagnosis of hypertension is made, start two medications from those three classes that we've already mentioned. Start at half maximal doses, don't start at quarter doses, et cetera, and up titrate every month until you get that patient under control. And we can discuss, we've already discussed that you can have different thresholds to start and different thresholds to stop, but whatever your control goal is, to get to that patient, that goal as quickly as you can. Organizations that have done this, Kaiser Permanente is one of the best examples out of California, have had dramatic results, starting algorithms with dual initial therapy and at half maximal doses, having a team-based approach, have different practitioners be able to follow the algorithm and administer pharmacologic agents where it's regulatorily allowed. And we just have to be more aggressive.
The term resistant hypertension has been used to describe some individuals with hypertension. What is it, and how should it be approached from a primary care perspective?
So the most accepted definition of resistant hypertension is suboptimal blood pressure control despite 3 blood pressure meds from different classes. And Dr. DiPette can correct me if that's not entirely accurate, if he has a different diagnosis, but I think that's pretty much what we mean when we say resistant hypertension. It's someone saying, I have tried this, and I have tried this, and I have tried this, and I still can't get their blood pressure under control. And I would say that I get this referral fairly commonly, okay? Not underlying kidney disease, but from a primary care physician, I cannot get their blood pressure under control. And usually for me, I look at the med list and say, well, that's because you're not picking the right medications, okay? Or not at the right doses, or either way, okay? There's not, off the top of my head, there's not one patient that I have that I can't get their blood pressure from 180 to 120 or 130 when I put them on my cocktail. Not saying that that's the only cocktail, I'm just saying it's one I found that works for me. And I also do it in a way that reduces number of medications, reduces number of dosing times during a day, and makes it very as streamlined as I can for the patient. And so I think for a primary care physician or other providers, an important thing they could personally do is be a little more ambitious, be a little more out of their box or comfort zone with the meds that they're used to using and that they've just gotten comfortable with using, and experiment to some degree with different doses, different medications, and overall be more aggressive. Do not be scared to give more drug. Do it in a thoughtful way. Don't do it in a reckless way, obviously, but don't take the 3 drugs, hydralazine, clonidine, and labetalol that you got used to in residency and think that's going to fit every person. Don't be scared to give more. Don't be scared to be aggressive.
I can't agree with that any more, Jennifer. That's the purest definition of clinical inertia, therapeutic inertia is that we're the failure for us to either start an initial medication or new medication when it's completely indicated, and or up titrate the dosage of the medication when it's indicated. Since there's such a diversity of approaches, and hypertension is such a general disease and has a plethora of pharmacologic agents, I think that's why most guidelines and organizations are now recommending that we actually just bite the bullet and we use more algorithms and more protocol-driven approaches. The World Health Organization has algorithms. Kaiser Permanente, that I already mentioned, uses an algorithm. Their algorithm starts with an ACE inhibitor and a thiazide diuretic. The World Health Organization has many examples of algorithms. Predominantly, they're starting with a long-acting ARB and a calcium channel blocker. In this case, it's always amlodipine. And they're starting 2 medications at once at half maximal doses. And then you only have one up titration when that patient comes back if they're not under control. If they're still not under control, add the 3rd agent. If you started with a renin-angiotensin inhibitor and a calcium channel blocker, then you add a thiazide or thiazide-like diuretic if their GFR, would support that. And then start a 4th drug if they're still not under control, spironolactone perhaps, and or refer the patient to people like Ben, that see the resistant hypertension individual more commonly than we're used to.
What are some of the more common secondary causes of hypertension, and how should a primary care provider screen and diagnose such causes?
So there's a pretty long list. I'd say there's 2 predominant ones that a primary care physician should always be thinking about. And I think that for the most part, they do. One is hyperparathyroidism, okay? And the other is renal artery stenosis. I think that my experience is that if providers have a patient that is refractory to their medication treatment and they just can't get them under control, those are always on their mind, okay? And those are pretty simple workups that they can have arranged or complete in their own office, even if it comes in conjunction with a referral. So renal artery stenosis, just get an ultrasound. Okay, now you have to specify I need renal artery Dopplers so that they can measure flows and those sorts of indices in the renal arteries themselves to either rule in or rule out that diagnosis. But you can order that at the same time you put in a consult for me so that I have that information when they come and sit in front of me. And we can talk about what that diagnosis means and how we're going to approach that. As far as hyperaldosteronism, so you can get a plasma renin to aldosterone ratio. Most labs will run that pretty ubiquitously, and then that gives me at least some indication if that perhaps is going on. Now, this is on every board question from residency to internal medicine to above. You have a patient that has difficult to control high blood pressure and a low potassium level. That is hyperaldosteronism until otherwise proven. So those are some, so if you see you've got a patient that's got a blood pressure of 180, 190, every time you see them, you're also noticing their potassium level is 2.8, 3.0. That ding, ding, ding. That's what you should automatically be thinking about. And if that is the case, or that's what you suspect, there's a lot of workup to prove that or disprove that. But at the end of the day, you still want to treat it as such. And angiotensin system blockers, be it ACEs, ARBs, spironolactone, eplerenone, etc. As far as renal artery stenosis, there's been a shift in decades. 20, 30 years ago, it seemed that the thought was if you fix the stenosis with stenting, that you're going to fix the problem. There have been at least in nephrology data, we have put that to bed, that is very rarely needed. They just need more aggressive medical management. And then again, specifically with RAS inhibition.
When should the primary care provider refer a patient with hypertension to a nephrologist?
They should refer whenever they feel they need to, or they feel that they have put in full effort and are not getting the results that they think are desired. And that can also be with a phone call. I mean, I think in the first or second part of this series, just talking about referrals in general, I'm happy to answer the phone and say, hey, and here I've got this patient, I've done this and this, I've had them on this. What would you add next? Or what, is there any, off the top of your head, any tweaks that you could consider or recommend, and give me another month or two and see if I can get this under control. If I can, I might send them on, but we'll give it a try. And that saves the patient a trip and a copay. That saves, me a time slot for seeing other patients when we're backed up too. That saves the patient, it just saves a lot. It could be as simple as a 5-minute conversation, if even that. For me to say, well, this is what I would do. If I saw them in my office and this is a referral, I would make these changes to the medications and see them back in a month and see what happens. If you want to go ahead and do that and see what happens, if it's not any better, send them on and I can maybe explore a little more. But if they're getting better, good. We've saved the system some money, and we've saved everyone a lot of time and energy.
Are there any final thoughts you would like to share with our listeners?
No, I think it's all kind of been said, but just kind of reiterate, don't be afraid to be aggressive with medications from the jump. Don't be afraid to up titrate these medications. I would say that, and this is my pet peeves, I never use clonidine, point period. I rarely use hydralazine and isosorbide. Now I know that there are some heart failure patients and allergies that may make those appropriate. But as far as getting consistent, stable, and appropriate blood pressure control, those medicines are just not ideal for me, okay? I try to limit the number of medications in general, and not necessarily, maybe not number of medications, but at least number of the pill burden a patient has to take as best as possible. I take into account their social economic status, and I don't prescribe pills that are brand new that I know that they're not going to be able to afford once their samples run out. I also personally try to avoid these combo pills, okay, because that makes it extremely difficult for me to titrate one or the other when they're in combination. So I will often split combo pills into their individual components. Usually it's cheaper that way for the patient to begin with. And B, it gives me just more fine-tuning control over changing one thing or another. And then I would spend a lot of time educating patients on how to properly take blood pressure themselves at home, okay? It is 5 minutes at minimum in an armchair, feet flat on the ground, using a blood pressure cuff that preferably is on the upper arm, and pressing the button and writing it down, okay? It's not running in after dropping the kids off at soccer practice, or running out because you want to get to the grocery store before they close, or right after you just got bad news. I mean, put yourself in the best, calmest environment to get a true sense of what your blood pressure is. And then also just take the extra 5 or 10 minutes to explain to patients how important it is and why we care so much about what their blood pressure is and how it affects their long-term health and other comorbidities, and help them to understand and care as much as you do. And I mean, that's a lot, but
It's wonderful. This has been an absolutely wonderful conversation. And Dr. DiPette, are there any final thoughts you would like to share?
Well, again, I'm prejudiced. To me, this is such a critical podcast to have done and to have such expertise with us and our nephrology colleagues. their opinions as well. No, I would just, again, pretty much reiterate what Ben said. We could have minor differences. Maybe one minor difference is that we're probably, as a generalist hypertension person or clinical pharmacologist, we're probably more favorable to fixed dose combinations because you can titrate them one time and get to maximal doses, but that's splitting hairs. What's more important is to get the blood pressure down. And the more rapidly we control the blood pressure, the more rapidly we improve cardiovascular outcomes. That's been demonstrated, especially for stroke. And again, this can't be any more important.
Thank you both so much for your time today. This is a wonderful addition to our series. And again, thank you for your time.
Thank you.
You're welcome.
We hope you enjoyed the practice of medicine. For more episodes in this series or SMA's The Business of Medicine podcast, go to sma.org/podcasts or subscribe to us on iTunes, Google, Spotify, or wherever you get your podcasts. For more information about SMA's mission, please visit sma.org. And thank you for joining us.